Almost back. Great, thanks everybody. We're now going to move on to, in some ways, something completely different, but you will see that this is very strongly linked to our understanding of relationships, is also being able to understand how we use this knowledge about our effective behavior in supporting a couple that might be facing sexual challenges. And one of the problems we have with being able to train doctors on sex is because our textbooks are actually horribly out of date, I'm sad to say. And we have found that medical science, although there's been amazing progress made in our understanding of sexual science in particular, a lot of that is not always translated through, definitely not to the schools. The schools are still a little bit behind, but even in our universities, we are still having to try and that's partly one of the reasons why I'm here today. And I know the universities are actually currently looking at revising their curriculum. So there's a lot of basic knowledge that we need to know if we want to be able to. Just realized I've been on mute. Okay. Hi, everybody. We're now going to be looking at completely different and not so different topic, which is about the tips to support a couple facing sexual challenges. And if we want to understand sexual challenges, we have to understand sex. And so this lecture is going to be actually covering our basic understanding of sex and sexuality. And I'll give a few tips in terms of how that translates into supporting people who might have sexual challenges. So one of the things you might find that if I know you haven't spent that much time in the clinical arena yet, but what we generally find in our clinics is that people don't often talk to sex about their doctors, and the conversation doesn't actually come up. And the big reason for that is that most people actually believe that the doctor is supposed to open the conversation. So most of our patients have got some sort of relationship with sex. Even if you don't have sex, there's a story behind why you're not having sex. Or you're having sex, the kind of sex you're having, and the effect it has in your life. It's pervasive in our communities, and yet it doesn't often come up in the consulting room. And we as doctors need to take opportunities to actually bring up the topic. And in any sexual health consultation, you obviously then it's quite of the obvious time if somebody's come in with an STI, for example, but any aging patient in our key populations, adolescents, in patients with chronic diseases, in palliative care patients, in patients with disability, it's quite important to actually open that conversation. What is happening in terms of your sex life? And the reason why a lot of doctors don't bring up the topic is because we don't actually know much about the topic. So women are more likely to raise the topic, but if they do so, they're going to do it indirectly. They'll have a little hint. And again, it will be up to us as doctors to decide we're going to follow that cue and ask more questions. And the more confident you are about sex and sexuality, the more you will be able to actually bring up that conversation. So it's important to gain confidence in talking about sexual health and sexual pleasure. And this is not such an easy skill to learn because we live in a society, in a community that does not actually promote healthy conversations around sex. So if you've got a couple who is seeking help, quite often when a couple does come in with problems or one of the partners come in, typically the kinds of things they will ask will have something to do with, they'll explain to you what's going on, and then they want to wonder what is wrong with them, or they want to know how that you can fix it, or they want to know what's wrong with their partner, and you want them to come up with some miracle thing to fix them. And underlying it, there's a question that also comes in, or a suggested question, and conferences and things, people quite often will come and tell you about something that's happening with them. And then this question of, am I normal? And I always found that an extremely painful question, apart from the problematic use of the word normal. But there's a lot of people have this experience that they are somehow deficient, and that is why their sex life is not what Hollywood is telling them to be. And the challenge for this is to do with what I'm going to call cultural imperatives. And this is also from Come Together by Emily Nagoski, where she beautifully describes all these imperatives we grow up with. And this is what the world tells us sex is supposed to be. So there's the sex imperative, where there's very much things we get told about who's allowed to have sex and how you're allowed to have sex and what sex is supposed to look like. There's the coital imperative, which means it's all about penis and vagina sex. But then there's also the variety imperative, which says you're also supposed to have oral and anal, etc., etc. There's the performance imperative. Cosmopolitan is famous for this, having all the ways in how you're now supposed to become a better lover or be more proficient in sex. There's the monogamy imperative, saying that only couples that are valid are where there's two. There's the body imperatives. We're all aware of that, of what a body is supposed to look like to be sexually desirable. There's the gender imperative that says everything we need to know and understand about sex and about gender all lies within the genitals. And there's the desire imperative, which I'm going to talk about quite a little bit later. So all of these imperatives give people the impression that they are somehow not measuring up. And so the most important thing, I think that's probably the only thing I'm going to teach you in today's session, and which is the message we want to give our patients, is that you are not broken. The way your body responds to intimacy and pleasure and sex is completely right for you. And implicit in that is the message that you are not inadequate or pathological or deficient or immoral or unworthy because of how your body relates to intimacy. And I think one of the challenges is that for us to know that somebody's not broken, we have to understand the extreme wide range of variety there is. So my emphasis today is going to be on teaching sexual and gender diversity, being able to understand the wide spectrum of how people's works. And humans are, as we know, generally extraordinarily diverse. If you are part of a big family and you've got quite a few siblings, you will notice how different you all are, even though you've got the same parents. And we know that a lot of these diversity is about 50% genetic, so what you get from your parents. And then there's also 50% of hormonal influences, environmental influences, all kinds of things that comes together and codes our subconscious for who we are. And most of these influences are beyond our control. We can't somehow magically create a particular trait by trying to influence this nature nurture subconscious influences. So for example, whether you are more introverted or more extroverted, whether you're more artistic or more analytical, whether you are somebody that's more reflective or pragmatic, whether you're somebody that's neurotypical or neurodiverse, if you're somebody who has a high BMI or a low BMI, if you've got light skin or dark skin, these are all things that's been coded and that this is who you are. And a big challenge is that we now in the world are looking at diversity and we're trying to grade diversity as if there are some things that are better than others. And the reason why this happens is because dragons don't like diversity. It's a safety thing. So all prejudice is driven by fear, by that survival mode. Remember, we have that survival part of ourselves. And the way the survival mode word is, as I said, is not very intelligent. So it's basically saying, if something's not like me, and if I don't understand it and I don't relate to it, then I'm going to see it as dangerous. And therefore, I'm going to try and find some way to negate it or destroy it or take it away. So prejudice is a natural reaction. And you all will have it if you're in a scenario where you meet somebody, you meet a scenario that you've never come across before. And the first instinct will be to be wary and going on, oh, hold on, I'm not sure about this. This is a bit odd. And if that gets built into a larger thought process of trying to now justify why I'm feeling wary, that's when you start seeing things like prejudice and racism and those kinds of things. So historically, what's happened is that it's those that's in power, that's got the most power in a society, which will then decide which of these varieties are acceptable and which ones are not. And if in our history, say in the global community, say over the last 700-800 years, it's been white, privileged, heterosexual, cisgendered men who has mainly made the decisions about who is okay and who is not okay. And although the world has changed considerably, it's still amazing how some of those old ideas are still so prevalent. If you look, for example, what's happening in America at the moment. So what happens is the dragons then has these systems of classification, marginalization, discrimination, and oppression. It's all based on a particular part of the human race that has power, using that power to suppress somebody that is not like them. And what we are teaching today is specifically a different perspective. And the reason why I have to bring this up is that it's amazing how sex brings all this up. So there's no topic that's probably more laden with opinion than around sex and gender. So as doctors, and you young doctors, almost doctors, you will all already have your own cultural, religious, and political perspectives on sex, on sexual orientation, on gender diversity, and that is all due to depending on your particular way, how you were raised, on the kinds of sex you have, on the kinds of people you hang out with, and your sort of frame of what you are used to. What's important, of course, to remember, which we do sort of know, is that, of course, this is not necessarily the same for our patients. And the person that's coming into your room might have a very different experience. My goal today is not to change your personal view on sex. Sex is an opinion thing. It's very much based within our own little lives of experiences. That's absolutely fine. But as the family physician, and this is the family physician paradigm, we have this sage superpower where even if we have our own ideas about sex and our own personal views on it, we can use our seeking part of ourselves to be curious about diversity and to explore differences, to become aware of what diversity is like and how our patients think and see and feel the world. Remember that biopsychosocial consultation you're going to do. We can use the care aspect of ourselves to affirm and embrace those different diversities. So being able to say to somebody, you are not broken, you are just, this is the way you work, even if it's very different from the way that the clinician works, that affirmation in itself is a very powerful part of providing family medicine care. And then a third important quality, which is very much also a higher prefrontal cortex quality, is that humility. So the humility to be able to assume that your particular views and your particular way of looking at the world are not superior to another person's view of looking at the world. And that's what the dragon does. So the dragon goes, I'm in power. I have all the money or the resources or whatever it is, or the political power. And therefore, my views are now more important than somebody, for example, that might be in a minority. And this is one of the big things we are trying to shift, is how do we create, as clinicians, a place of inclusivity and diversity in our consulting room. So I'm going to introduce you to sexual diversity, and I'm going to introduce you to the concept of sexual intelligence. So when you have a couple who is having to engage in a sexual relationship, a sexually intelligent relationship, which is obviously a sage relationship, has these 4 components. And for those of you that know emotional intelligence will notice it looks a bit the same. We have to be able to reflect on our sexual selves and understand our own sexual selves. And we have to be able to manage and communicate that sexual self to somebody else. And we have to be able to understand our partner's sexual self and be able to manage that relationship. And what happens in the world of sex is we don't actually have a language quite often to talk about these things. So you have the Grey's Anatomy or the Bridgerton, where people just like dive through the doors and fall passionately on the bed and no conversation ever happens. And people are just automatically supposed to know and understand how the other person's sexual self works. But we're going to look at this extraordinary diversity and the importance of how we communicate that diversity. So a very lovely tool, and I'll send, I think, I don't know if you've got this one, but you'll have some of them, but I'll send you this one because I've slightly expanded it. It's something called the Gender Jabu, which is the South African version of something called the Gender Bred Person. And it looks at various diverse perspectives on how we can understand gender and sex. And I'm going to look at it from 3 different points of view. The first point of view of who you are, the second point of view from who you love, and the third point of view from how you love. So let's start off. Now, with you guys, I'm actually going to go quite quickly because I actually expect most young people are very familiar with these concepts. When I teach the older profs and the older medical officers, we have to go very, very slowly because it's all very new. But our younger people are much more aware of diversity. So apologies also if I'm going through things that you're already very aware of. If it's an area that you're not so well aware of, please focus a little bit on the way we use language, because that's quite important also when you communicate to your patients. So when we talk about sex and gender, we have what we call biological sex. And the way we refer to biological sex is the sex that you were assigned at birth. And this is what the midwife says when you are born. Either, oh, it's a girl, or oh, it's a boy, or oh, I'm not sure if, for example, somebody's got intersex and they might have different sexual organs. And there's different things that determines biological sex, from chromosomes to your genitalia, whether you have ovaries or testicles, whether you make testosterone or estrogen, whether you've got breasts or beards. And it's important to note that actually there's a lot of people who don't necessarily fall into that clear binary of being completely women and completely male. So we know from, and these are just stats that's written up, that about 1 in 1,000 births are intersex, which is as common as twins. So that's differentiation of sexual development. But we actually notice if you were to go and test everybody's chromosomes or do ultrasounds on everybody, or look a little bit deeper, you might actually find that there's quite a wide range on each of these. And it's not so easy to just put people into these two boxes. And we're seeing biological sex now much more as a spectrum between a so-called female and so-called male. The second concept is that of gender identity, and I'm using the definition here from the Yoga principles. By the way, thanks and credit to Alma for some of these slides. And the Yoga principles defines gender identity as each person's deeply felt internal and individual experience of gender, which may or may not correspond with the sex assigned at birth. So I think most of you are hopefully familiar with the term transgender. We will go through the details of the terms just now. But I think it's important to have just a couple of slides in terms of our understanding currently about transgender, because it's actually changed quite dramatically in the last 20 years, 10 years even, in the medical field. We now know that about somewhere between 0.5 and 0.7% of the worldwide population is transgender. Don't have excellent stats because there's a lot of countries yet where transgender is not recognized, and so we don't know. But that stat's pretty much standard no matter where you're looking. And we do understand that where your gonadal sex, your ovaries and testes and all of those things get formed in the first trimester of pregnancy, that your gender identity is largely laid down on the second trimester of pregnancy. And part of that is genetics. So you could actually, some of that neural networks are genetically determined, and some of them will also be influenced by hormones on the brain, by various other factors in the pregnancy, the same as there's various factors that influence whether you're introverted or extroverted, etc. So similarly to the way personality is formed, we find that gender identity is also laid down. And so what's important in a lot of the science now, and especially in endocrinology, is that our understanding that these different forms of sexual orientation and gender identity, we now understand is just variations of human diversity. It's just all the different ways in which people develop. Because of this understanding, we have gone through a process in medicine to depathologize being transgender. And so it's been taken out of the DSM-5 as well as the ICD-10 as actual disorders, and is now called gender dysphoria, which just based on that experience one has of that difference between your biological sex or your sex assigned at birth and your gender identity. And in 2019, in May 2019, the WHO actually in one of their assemblies officially stated that a trans or gender diverse person does not mean to suffer a mental disorder. I quite often get asked why we're seeing so much of it recently. So there's a lot more transgender and gender diverse people that are visible also in the media. And I think a useful example is that of the development of left-handedness. So in 1939, it was not cool to be left-handed. It was considered to be unhealthy. And children had their hands tied behind their backs and all kinds of weird practices to force them to write with the right hand. And only 2.1% of the population as adults was found to be left-handed. As we discovered that neurologically, you should probably not force children to do things that they don't want to. It's actually much healthier to let them develop their left hand. And by 1972, we can see now 12 to 14% of the population are now left-handed. And we'll see a similar thing with transgenderedness, that as it's becoming more acceptable and people are finding labels to explain their experiences, we are seeing more and more people able to say, oh, actually, this is what I or who I am. So just some terminology. I'll do this quite quickly because I think you guys are good with this. Cisgender is when your gender identity and sex is assigned at birth are aligned. Transgender people, if it's a gender identity that is different than the sex assigned at birth. And gender diverse is a wide term because gender in itself is quite a culturally determined concept. Everybody's got a slightly different version on what they even consider to be male or female. And in gender diverse, there's lots of different ways in how people describe themselves. It does not necessarily fit into that male-female binary. So I'll just give a couple of examples here, and this is important just from a language point of view. So when somebody is a transgender woman or a trans woman, that is somebody who was assigned male at birth, they identify as a woman, and we will refer to them with the pronouns she or her. Transgender man or a trans man or trans masc is somebody who was assigned female at birth, identifies as a man, and we would use the pronouns he or him. And then non-binary or gender fluid, genderqueer, agender, there's different terms. It's not your job to figure out what the term is. Just ask people and they will tell you what the term they prefer to use and what they think it means. And that can be somebody of any biological sex, and where this gender identity does not fall so nicely into the binary categories. I'm sure you guys are quite good with the they, them pronouns for friends that you might have that falls into these identities. And there's also various neopronouns that one can use. It's also just good to mention gender expression. So the way you dress is not necessarily directly related to your gender identity. This is Jonathan Von Ness. They are a non-binary. They're one of the presenters of Queer Eye, and this was at one of the Emmys, and you can see they've got a beautiful mixture of gender expression, the lovely beard and the beautiful dress and the gorgeous shoes. And important is you can't look at somebody like that and make a decision on what their gender identity is. You have to ask. The gender expression has got no relationship necessarily to their identity. Right, so that's easy. Sexual orientation, I think we're very aware of, and it's just important to remember that sexual orientation and gender identity is not the same thing. So gender identity is how you experience yourself. Sexual orientation is who you love, and the one does not denote what the other is going to be like. So it's also now historically interesting to look back, because it was actually as late as 1973 that the DSM removed homosexuality as a pathology, and it was only in 1992, that's very recent, that it was actually removed as a diagnosis out of the ICD. So we've been quite behind in medicine. Politically in South Africa, until 1994, it was a crime. But then we really made up for it, as our constitution is now one of the fairest in the world, and was one of the first where sexual orientation was actually mentioned within our constitution. Of course, the rest of the world is not so friendly. We've seen recently now in Uganda as well, with some of the changes in law, and Ghana now has also made their laws more strict. And there's actually still criminal prosecutions for people who identify as gay. So the terminology also I'm going to do very quickly. And you will see here, I've got two sides, and the one is going to look at sexual attraction, and the other one is going to look what they call romantic attraction, and I'm going to cover that in more detail in a minute. But these I can just fly through, right? So heterosexuality, same attraction to the opposite gender, homosexuality, attraction to the same gender, bisexual to both male and female, pansexual, the gender doesn't matter. And you can have the same definitions for romantic attraction, which we will cover in a minute. So falling also under the way we relate to other people in terms of our sexual preferences, you also get polyamory, getting better at pronouncing that. And this is what we call ethical or consensual non-monogamy. So these are romantic or sexual relationships with multiple partners at the same time. The key word here is consensual. And when we talk about consent and sex, we always talk about enthusiastic consent. So this is not consent, oh, I will stay in the relationship and you're allowed to have an affair because I don't want to lose you. Everybody must be enthusiastically involved in saying yes to this. There's lots of different types. I don't want to cover the types. I just want to show you that some of these different terminologies. And again, you can ask people to explain themselves what kind of a relationship they're in. A triad or a quad, for example, will be 3 people in the relationship or living in the same, three nesting partners in the same house. A quad might be 4 people, or you might have somebody like hierarchical where there's 1 nesting partner, so a couple that lives together in one household, and then they have other secondary partners outside the household. And I'm not going to cover all of them. I find it interesting that the polyamory world is quite, should we say, a little bit judgmental about polygamy. This is usually more overseas, which in South Africa, we do have polygamy in, for example, KwaZulu-Natal quite big, where there's a cultural or religious practice of having multiple spouses. And again, if there's enthusiastic consent all the way around, I think that also qualifies as a polyamorous relationship. So now we're going to talk about sexuality itself and how you love. And this is the area where people are not actually so confident. And I even find within queer communities, when I teach in queer communities, this is the one that causes the most, I would call it excitement, because it's an area that's not very well described. And the challenge with this is what I'm going to call the sexual desire imperative. Remember, I mentioned those cultural imperatives. And the sexual desire imperative says that all relationships should have this spark at the start. And during your relationship, you have to keep the spark alive. And that spark is usually meaning like a sexual desire. And that's seen as the only correct, healthy, normal kind of sexual desire. And if you don't have it, then it's not worth anything worth having. And that if you have to plan sex or take precautions, then you don't want it enough. You need to have that, that sex of bursting through the doors and overwhelming sexual desire for somebody else. And if your partner doesn't respond to you spontaneously with massive amounts of sexual desire, then they clearly don't want you enough and they clearly don't love you enough. And so we have this obsession with libido. How much libido are you supposed to have? I'll just put it out there. It's complete and utter rubbish. And the rubbish was partly created, I'll show you the studies by now, by some very biased science that was done 30, 40 years ago. So I'm going to introduce a completely new prerogative. And again, Emily Nagoski and Rosemary Basson, some amazing people in the world of sexual science, has started expanding our understanding of physical intimacy. And I'm going to contrast two different ways in how we experience physical attraction to other people. And I'm going to call it lust versus care, because we have those lovely affective spaces. And what's important about these is that most people have a mixture. But I'm going to first explain to them nicely as a polarity, because some people do find that they are actually mostly have one or the other. But the reason why they're sometimes poorly understood is because some people have quite a mixture of the two, and so they tend to confuse the one with the other. And these are all bodily attractions. So I'm not just talking about an emotional attachment to somebody. I'm actually talking about a scenario where you want to touch somebody or you need to be touched. And the important things to realize is that lust is not the automatic default. The reason why we think lust is the automatic default is because of the Masters-Johnson-Kaplan model of sex response. You might have done this through your bioscience years. And they did this study that these sex labs where the couples came in and was studied, and there was criteria. So they had to be heterosexual, they had to be married, they had to be cisgendered. The woman had to be able to have an orgasm during vaginal sex, which is very uncommon. And they created this lovely cycle that when you like somebody, you're supposed to feel sexual desire. When you get under the covers, you will have massive sexual arousal that will be built to an orgasm and then resolves after that. And that's sort of, it's both Hollywood and medical science has taken this on as the imperative. This is the way sex is supposed to work. And if your body does not do this, then clearly there must be something wrong. And this is the imperative we're trying to destroy. So I'm going to run through these two different polarities. And as I say, it's a whole spectrum, a whole range, and they do mix. And there's other things that can fill in as well, but let's just look at this one polarity for the moment. And I'm going to start off just talking about the one we all know, which is the lust. Now, sexual attraction, physical attraction is always hormonally mediated. You can't experience a physical attraction to somebody if there's not a hormone in play. And with sexual desire, you have to have testosterone. If you don't have testosterone, you will not experience sexual desire. It's a necessary hormone for that. Quite often it's triggered by visual stimuli. And the kind of experience you have if you're attracted to somebody is sexual desire. So what we call lust or being horny. And if they get under the covers, the sexual arousal is actually it's this tension that builds. So the heart rate goes up, the blood pressure goes up, the muscular tension goes up. We always say it's like climbing 2 flights of stairs. And the whole point of it is to get towards orgasm. So the sexual desire and arousal actually drives towards orgasm, just like we had in that little table from Masters, Johnson, and Kaplan. If you look at the body, if you were to study the body, you will notice that the erogenous zones wake up. So remember, in normal life, the erogenous zones are fast asleep. So we're normally not aware of what's happening between our legs. But in this kind of scenario, those areas actually wake up and become intensely engaged in what's happening. Now, what's interesting about hormones is they also have a little bit of an emotional content. And so testosterone has something about it that has also to do with being successful, being powerful. And it's also a hormone that is associated with aggression. So I thought I'll give you a little bit of a feeling of what testosterone feels like on an emotional level, right? So that's our World Cup. And when you're watching the World Cup and you watch Siya Kolisi lift that cup above his head, you all have a little experience of testosterone and a feeling of success and power, and we got it. But it's not the only way the world works. And so now I want to introduce care and another kind of physical intimacy. And actually, you are all aware of this. And I do find that some people, a bit more, if I'm going to be binary, a bit more on the girl side, are more aware of being able to understand this as something completely standalone. So, for example, when I'm talking about a group that a very always or large group that feels this lust prerogative is our teenage boys. So about 90 to 95% of boys will have predominantly lust as the way that they experience attraction when they see something that they like. And so for them, they quite often have a mixture of both lust and care, and it's more difficult to unpack the two. But it is quite a large percentage, we think, and we don't know the exact statistics of some people, particularly of those assigned female at birth, will have a different way in how they experience physical attraction. And the stimuli is different. So often this is based on connection. So I feel connected to somebody, somebody pays attention to me, I really like somebody, I link to somebody, I bond with somebody. And this can also be imaginary. So even if you have a crush on somebody, you will, in your imagination, it's not so much about the physical might play a role, but it's much more about feeling this connection to that person. And the physical experience is not sexual desire, but sensual attraction. So it's that typical infatuation or crush. So it's very possible to have a complete crush on somebody and have the knees go weak and the eyes go sparkly and be slightly hysterical most of the time and not actually experience any sexual desire at the same time. What you experience in your body when you actually get on the couch and maybe you end up having a nice schnog or having a nice cuddle is that actually the arousal is quite different. So actually your muscles there's actually decreased muscular tension, decreased blood pressure. A good example will be if you've ever gone for a really nice massage. So when you're being massaged, you'll have that feeling of sensual pleasure. That kind of arousal is very experience focused. So it's not driving towards orgasm, for example. It's much more about the more you touch, the more you like touching. If boyfriend or girlfriend is supposed to go home, but they can't leave and come back for one more kiss and one more cuddle and one more hug. And it's just something that sort of builds and builds as a circular process. So here the erogenous zones are still completely asleep, and all of the arousal is happening through touch, connection, cuddling, and kissing. And again, there is an emotional content which has to do with the oxytocin that gets secreted during this kind of attraction, which has to do with attachment to somebody, with connection, with bonding with somebody, and with affection. And that's why we often call it the love hormone. So just a reminder, if you're feeling a little bit confused about which is what, quite often the two are mixed. So if you're somebody who's got quite a strong lust way and how you relate to whoever you are attracted to, you might have both, and both might be very strongly mixed. So you might have a very strong experience of both, and it's quite difficult to pick them apart. But it's good to understand that there are some people who only feel that lust imperative when they're attracted, and they don't actually have that much of this. And they don't really understand much of this because their bodies don't work like that. But similarly, there are a substantial number of people who are mostly sitting on the right-hand side of this schema and predominantly feel attraction through sensual attraction and don't actually feel it through sexual desire at all. So, there's our oxytocin picture. Apparently, oh, sorry, I keep on losing it. There we go. I'm hoping there's a ah in the background. So whenever we are nurturing and whenever we are feeling a feeling of, oh my God, so cute, that's a bit of oxytocin that's being excreted there, and has very much to do with our instinct to actually take care or attach to something. So another concept I want to bring here that is linked to all of this, and this is also Emily Nagoski, she coined these two terms, spontaneous desire versus responsive desire. So remember I said that the desire imperative says that everybody should feel desire through this sexual desire. But actually not everybody's bodies works like that. And I'm just going to show you how it might be different in different people. So some people have spontaneous desire as their main way that they experience desire. So we're now talking about the sexual desire, testosterone cycle. And so they actually have this desire. They see somebody, they feel a feeling of desire, and then that's going to lead to arousal and to pleasure. Because they have spontaneous sexual desire, they also often have spontaneous sexual fantasies. Again, think of your teenage boys. And they like pornography or sexually explicit material. So if you are in a state of desire, then you will enjoy erotic material, for example, and their masturbation will be quite a bit more common. But you do have some people who are predominantly on that oxytocin side of the cycle and may not feel any spontaneous desire at all. I'm going to repeat that because this is one of those things that's not known. Some people do not experience spontaneous desire. They can, however, experience desire in specific contexts. So once they are in an area where they're safe, they've cuddled for quite a while, they're with somebody in a stable relationship, they might actually have desire as a response, and their bodies might end up going into a state of desire, but they never have spontaneous desire unless the context is right. So they may have little or no sexual fantasies, and if they do fantasize, it'll be romantic fantasies. And if they do like movies or novels, it'll be romantic movies or novels. And if they do see visual imagery of sex, like pornography, for example, they would actually be it'd actually be turned off by that. And people with responsive desire may never or very rarely actually masturbate because their bodies do not respond in that. We have a tradition of trying to make responsive desire into a disease. There's even this hyposexual disorder. If you don't have enough libido, that there's something wrong with you. And we need a lot more data in terms of how much of our society and community actually sits on the responsive desire part of the axis. So some more terminologies around that then. Asexual is a person who does not experience sexual attraction to others. So that's that testosterone type of experience. So there are about 1% of our population that is not going to have, and particularly here, we're talking about spontaneous attraction. And an asexual is a term that includes lots of diversity. So there are people who are quite sex negative. If you are neurodiverse and you touch averse, for example, sex might be quite repulsive as a thought. Some people are quite neutral about sex. They're not particularly minded, can't really be bothered. And for some people, they actually want to have sex within their relationships. They think it's a normal, healthy part of life, but they just don't respond through sexual desire. There are some related identities. So gray sexual are people who might occasionally have sexual interest. And then demisexual. So I found this term only recently in the last year, although I've been teaching responsive desire for more than a decade. And interestingly, demisexual there, the definition is you only feel sexual attraction once you have a strong emotional connection to someone. And that's actually a beautiful description of responsive desire. And I've got a hunch there's quite a large number of people that might actually fall under the demisexual umbrella, which actually falls under the asexual umbrella. And that's the flag. So also now interesting to note that 74% of asexual people may experience romantic attraction. So this always causes a lot of confusion. So romantic attraction, remember, is that cuddling, kissing. And you also get some people who are aromantic. So you might also have somebody who has strong sexual experiences. They're quite happy with a hookup, for example. They very much relate through the lust side of things, but they don't really, the cuddling and things are, again, like with the asexuals, some of them will be happy to include it. Some of them actually don't very much like that side at all. So an aromantic person does not have any romantic attraction to others. And again, there's also gray and demi-romantic. So demi-romantic might be, for example, somebody has lots of hookups, lots of different relationships, don't really commit to any of them, only have sexual relationships. And then when they eventually find a partner that they're emotionally attracted to, then over time, they can also actually engage in that emotional oxytocin and bonding attraction. So there's also other hormones that can play a role. And there's lots of sexual practices that can spice things up a little bit with putting a bit of adrenaline into the mix. And I like to give the example of roller coasters. So some of you might enjoy roller coasters. We don't all enjoy roller coasters. But when you go down a roller coaster, for some people, that's quite fun. But if you were going down, I always talk of the Butterworth Pass. I'm not sure if any hectic passes you have around PE. But if you're going down a very steep hill and your brakes give up, the same experience is going to be horrific because it's not safe. So very important when we talk about adrenaline and spicing up a bit of sex, it always happens within a realm of safety. And this is sometimes very poorly understood. So for example, sexual fantasies, sometimes people have sexual fantasies and imaginations about things they would never want to see happening in real life. But in their sexual fantasy, they have control over what's happening. They feel safe, and therefore they can explore things. Sexual role play and cosplay is another example of that. And then I always like to give BDSM as an example of what I call adult mature sex. Because BDSM, if you're going to be regularly involved in BDSM, it's extremely important that you feel completely safe. And so BDSM has got the most amazing informed consent process. People really sit down, they talk exactly what's going to happen, they talk about what they want to see, what they like and what they don't like, and how far they're willing to go with whatever's going to happen. They have a safe word, and there's a very strict respect during the play that if any person at any time say, no, I don't like that, or enough, that the other person listens and respects that. Otherwise, you're not going to engage in that again in the future. And I always think if we can do the same amount of informed consent to our vanilla missionary style sex might be a whole different story. That also goes for kink. And then the only one that is dangerous that you need to be aware of is that if your sats are low during orgasm, it can enhance the orgasm, apparently. And you do get people who get odd ideas off the internet on how to asphyxiate themselves during orgasm. And of course, occasionally things can go wrong and they might end up in your A&E. That's the only one that's dangerous. Everything else is actually very, very safe. So just the last couple of types of attraction. So we've covered lots of different kinds of attraction, but you do also get aesthetic attraction. So that's just when you are with somebody because they're gorgeous. There's emotional attraction, which we pretty much have in all relationships, in our friendships as well as in our romantic relationships. And people who are asexual or aromantic or both may be in a relationship based on aesthetic or emotional attraction. So you can have two people who are both aro-ace, so aromantic and asexual, who are very, very closely linked to each other. Their relationship is not romantic in terms of physical interaction, but they've got a much closer emotional connection than, say, just a friendship. And we call those queer platonic relationships. I've got a little comment just on gender-based violence and abuse, because we sometimes confuse rape with sex. And now that we understand that model of when we were talking about the different emotions in the dragon, is that rape is not about sex. So the erections that a person who rapes gets is not about lust, actually. It's about the power access, and is usually part of rage as a way of trying to dominate through power. So what happens with somebody who does something like that, and I think it's similar when, for example, somebody beats somebody else up for any of your abuse or gender-based violence, is it gives the perpetrator a brief experience of physical power. They feel physically, bodily better because it boosts their testosterone for a moment. Clearly, they're on survival mode when this is happening, and that feeling will go away as soon as that is over. So this is helpful when we think about if we want to try and prevent gender-based violence in our communities, we need to understand what kind of men, well, not just men, but predominantly men, are vulnerable to engage in this kind of thing. And the first thing to understand is they'll always be in survival mode. So you will not assault somebody else if you're on your sage mode, clearly. So these are usually people who are under severe strain or stress of some kind. And usually what you will find is that they have an underlying subconscious experience of powerlessness or lack of agency. So this can be in any part of the different, doesn't matter how rich or poor you are, but somewhere in your life, you feel that you are not able to live the life you want. And that's usually people who have been abused themselves or traumatized themselves. So they're in dragon mode, and that dragon feels like it has no power. And so they get a certain experience out of having these out of gender-based violence. And people like that have got very poorly developed emotional competence. So they are not engaging from the sage level. They're not self-aware. They're unable to reflect on what's happened. They've got poor inhibitory control. And so you can see here, underlyingly, we really need to look at the health of our families and our education system in terms of how we help our young men to be able to have a feeling of agency and to be able to access that sage part of themselves if we actually want to beat this cycle. So great. I see we had 4:01. Alma, can I just check how strict your cutoff is? Because I know with us, we sometimes have to go. Otherwise, we can just actually wrap it up there, or whether I should spend another, because we started a little bit later, if I should spend another last 10 minutes on a few aspects of intimate relationships. If Alma is still with us. Maybe one of the students can tell me.
Not typically too strict, Dr. Muller. It generally depends on a consensus.
Are you guys happy for me to continue for a few minutes? For those of you that have to go, you can go and it will be recorded. Shall we do that?
I think that should be fine, yes.
Okay, cool. So I'm just going to start putting it all together. And yeah, I'll skip the odd slides so we can actually get through them. But we now understand that pleasure is affected by lots of different things. And you can imagine if you combine desire, bodily pleasure, life circumstances, relationships, gender identities, that you get lots of different ways in how people respond in terms of sexual diversity. And so when you have a couple in your room, let's say you've got a couple who's been married for a couple of years, and when you chat to them, you discover the husband is somebody up here. He's got a lot of spontaneous desire, and he predominantly interacts through lust. And now his wife is somebody who's actually got predominantly responsive desire, and she predominantly likes the cuddling and the kissing. And if they're not able to communicate about that, that might cause a huge problem within their sexual relationships. And the problem is usually we're trying to fix the one partner. So either the man mustn't want so much sex, or we're trying to fix the libido of the woman, rather than being able to affirm that both of them are not broken and how can we help them. So interestingly, when we think about sex, sex is all about the dragon, right? So when you're busy having sex, your brain is usually not engaged and should hopefully not be engaged. But actually, if you want to have good sex, you need to be able to talk about sex before you're having sex and also after sex, to actually being able to figure out all these kinds of things. So the book there, Come Together, feel free to please go and have a look at it. And Emily Nagoski has got this lovely proposal on how she works. She's a sexual educationist. And what do you do with this desire imperative? And she tries to get people away from focusing on desire and rather focusing on pleasure. So pleasure is what matters. Do you have pleasure in your relationship? It's not about how much you want sex. It's not about how much sex you are having. It's about how much you like the sex you are getting. And if we can focus on people being able to like sex, that can make a difference in terms of helping them find some common ground. And so pleasure is the measure of sexual well-being. And there's some lovely projects. I won't talk about the pleasure project. And quite often when you want to look at a couple, if you want to sort out their sexual relationship stuff, though, you first need to be able to make sure that you can sort out their relationship stuff. So you can't talk about sex if there's not admiration and trust in that relationship. And remember, we talked in that first chapter about how we solve our problems using that calm, warm curiosity. Also important with sex is to realize that it's not actually urgent. It does not have to be solved today. There are more important things in life than sex, bizarrely enough. And it helps to make a couple realize, well, hold on, there might be other things that you need to sort out first or look at first before we worry about sex. And you're going to help the couple to work together to spend a time communicating about sex. And what you're trying to do is you're trying to create a context for shared pleasure. So rather than now try and get to desire, you start looking at, hold on, what kind of pleasure do you like? And how can we create a context where we both experience pleasure? So Emily calls this the third thing. And that's when a couple looks together at something, and she gives this lovely example of having a shared garden. So your sexuality is a shared garden. It's a little project we're both going to do together, and we're going to figure out what we like in our garden. And your role as a doctor is to help out, pull out all the weeds that's been planted in that garden by society and media, the culture, by giving this message of you are not broken and the way you want pleasure is perfectly fine. You can use that gender taboo to help people understand and talk about who you are, who you love, and how you love, and being able to affirm each other's ways of enjoying pleasure. And that sort of lies your base plan. And then she's got this lovely thing called the emotional floor plan exercise, which is the only thing I wanted to quickly cover with you guys. And she talks about how do we get to a place of lust? So as I've noticed, mentioned, so some people don't ever get to lust at all. That's also fine. So it depends on what rocks your boat. But for some people, they have responsive desire, and to be able to get to lust, they have to move through one of these, what she calls emotional rooms. So she gets couples to draw up their own emotional floor plans. Everybody's different. And which particular room is a room that gets you to lust? So for some people, it's the cuddling, chatting, spending time together, sort of the romantic evening, and intimacy will get them to lust. Some people, it's play, having a date, playing a game together, bringing some sex games into the whole thing, and laughing and having humor. And for some people, it's about exploring and doing like interesting exercises and studying things around sexuality. So it's very different for everybody. And we need to find out how different people's rooms work and where can we meet together in one room and what does that look like that helps us to get towards lust or sexual attraction, or even if it's just cuddling and intimacy to get us, how do we spend time together in that care space? Another thing that's useful when you talk about the emotional floor plan is that once you understand where your route is towards lust, is to be able to understand what are your accelerators and what are your brakes. So your body automatically has ways to try and look for, oh, might be good to have some sex now, or oh, it might not be such a good idea to have sex now. And our accelerator is that part of us that notices all the time possible sexual stimuli out there, either in our body. So, oh, I'm having an erection. I feel like sex. Or, oh, look, there's a bit of porn there. I find that quite interesting. And that actually turns me on, or not, as the case may be. And everybody's different in terms of what kinds of things gets their accelerator going. One of the questions you can ask to try and figure out about your accelerator is that if you think I want to have sex, what is it about sex that you want? What is it what you want to get when you have sex? And that might tell you a little bit about your own accelerator. But your brakes can be anything that makes you feel unsafe. So anything, if you are, that you sense, think, believe, or imagine, any internal body sensations that signal danger is going to be a massive brake. And for most people, it's not so much about accelerators, but it's starting to recognize brakes. So any relationship conflict, any stress, if you're exhausted, if you've got body image issues, if there's sex negative cultural messages, if the kids, you're worried the kids are going to hear you, all of these things are massive brakes on sexual desire. And watch out, obligation, major break, if you're having sex because you think it's a good idea. So part of doing your shared garden is being able to understand what's the accelerators, what is my brakes, and then being able to create a shared context. So all you're doing as a GP or a clinician is being able to start educating our patients. And I've got little printed out pages that I use where I teach them about dragons, I teach them about emotional floor plans, and I teach them about sexual diversity. And your big message is the most powerful thing you can probably do for your patients is giving them good information and explaining to them that they are not broken. And then if you are wanting to do some sexual counseling, we don't usually do that as GPs or as doctors, then your focus is helping them find this shared context for pleasure. Just lastly, important, if you've got partners where both are struck in dragon mode, so you've got 4 people who are showing those 4 horsemen, they're both stressed and freaked out, they need therapy. If they've got somebody if they are really hurting each other, so they're beating each other up or emotionally abusing each other, you need therapy. If one partner is not coming to the table at all, they probably need somebody professional to work with them. Or if there's other high risk factors, so if somebody's abusing substance, if somebody's got a severe mental illness, then maybe rather get a therapist involved. And finally, please don't assume that your patient's experience of sexual pleasure is the same as yours. Don't assume you know a person's gender identity, sexual orientation, or sexual preferences based on how they look or sound. Don't just assume you know how a person wants to describe themselves or to their partners, and don't assume all of your patients are heterosexual and cisgender. Thank you very much, everybody. Those are some of my favorite books. Particularly Effective Neuroscience is very heavily academic and deals with all of the brain hormones for emotions. Maybe not so much for you guys, but Come Together, I think, is a must read. Beautiful book in terms of explaining a lot of the stuff that I've covered comes out of that book, and she goes into a lot more detail. For those of you that want to know about your own saboteurs and understand your dragons a bit better, I've put a QR code there for the saboteur assessment. If you Google positive intelligence, Shajar Chamin, you will also find it. And that's just a great way to, it's like a free tool that you fill in and it will send you a whole report on your own saboteurs. Thank you very much. I would like to open it to any questions, and I particularly would appreciate any comments or feedback on this presentation, because this is the first time, obviously, that we're doing this with fourth years. So we need to know, do we want to do this more often? Should we include it in the curriculum? Do you want it included earlier in a curriculum or later in a curriculum? Are the things there things you think I should just rather not cover because actually you know it all? Or do you think there's things that we actually need to add already at this point? Is there any follow-up sessions you would like? I really would appreciate any feedback in the chat. You're also welcome to do it anonymously if it's quite sensitive. But we are busy developing education